So a couple of things, I guess, before I start. With Dr. Norrie's talk and some of the ones even yesterday, it's kind of interesting to see some of the points that they made, and got lucky, it actually tied into mine a little bit. So I'm going to talk to you again about adhesive capsulitis. I know it said post-surgical on your sheets. It's actually going to be the post-surgical as well as conservative management of adhesive capsulitis, both. Again, just kind of the general ligament structure of the shoulder that Dr. Norrie was talking about that gets all inflamed. And again, it's typically the anterior, inferior, and posterior capsules where we're normally a little thicker, that gets really thick and balled up. Risk factors, he had touched on those as well, but it's usually from some kind of an event or maybe a viral type of thing, sometimes just out of the blue, diabetes, all those kind of different incidences can lead to this. And again, like he was mentioning, a lot of the literature actually talks about that there's probably some kind of almost like an autoimmune type of a response to this, because it's kind of an overreaction of your body. It keeps producing more and more inflammation into the joint, which causes further adhesions and fibrosis buildup. Some of the other things he had mentioned: diabetes, CVA, overactive thyroid, cardiovascular disease, tuberculosis, Parkinson's. And then also women between 45 and 55 is the highest range. So they actually think that there is also some kind of maybe even a hormonal type of thing as the bodies are changing, that this will cause some of the differences in the collagen and formations as the inflammation takes place. And again, it's an inflammatory process, and it begins in the soft tissues. And he had mentioned that when you look through a scope, how it gets really red and inflamed. And again, that's what you're typically going to see in that early phase. It gets really angry, it's painful, it hurts all the time, they don't want to move their arms, so there's a lot of self-limiting type of behaviors. As the scar adhesion and formations begin to develop, they start to lose that ability of the humerus to kind of glide, slide, and roll within the socket like it's supposed to. And it goes through those three phases. And the biggest thing with this, and we talked about education of our patients, this is a diagnosis that's really important to educate your patients, because it's different for everyone. The length of each of these phases is different, even though they go through all three phases, irregardless of what our treatment is. So, you know, your patients need to understand this isn't going to be gone on Friday, it ain't going to be gone next Friday. This could take months, and each phase is different. And our goal is that we want to get them out of that first phase as fast as we can, because then they produce less adhesions. So, as he was mentioning, again, you don't want to be excessively rough in that first phase, but you want to keep them moving and try to get them to avoid that self-limiting behavior, or they're going to get tighter. And again, it's a slow, vicious cycle. That first phase is that freezing phase. It's kind of ironic they call it freezing because it's like red, hot, painful, so you'd think it's more on fire than freezing, but that's what they call the first phase. The second one is that frozen phase, where again he had mentioned the pain has kind of subsided a little bit, but they're having a lot of stiffness. It hurts when they do stretch. I would start to be a little more aggressive with stretching in this phase, and again I'll talk to you about kind of what recommendations with literature is found. And then that thawing phase. One of the other things I wanted to point to is if you look at the picture on the bottom right, you can see that those fibrosis fibers are laying all over the place. As a hand therapist, we talk about scar formation a lot, and this is one of the things that we look at. When you have scars or even adhesions in the shoulder, your body's natural way of healing is to lay collagen fibers kind of everywhere it can, kind of like a patchwork. Okay, and they call it a bird's nest effect. So the problem with that is that doesn't stretch. Your collagen should be in a nice linear or a kind of a parallel alignment, and that allows for better movement and stretching. That ain't gonna stretch. Okay. So again, with the scar formation, you know, it's a kind of a scaffolding process where they lay all that formation together. So our goal is to try to get away from this bird's nest type of effect with scar formation, shoulders, hands, anywhere else, and get it to a more linear alignment. That's what it should look like under a microscope, and this is what it looks like when they have a mess. Okay. So again, with the treatments, the steroid injections, that's one of the things they had mentioned, manual manipulations, referrals to occupational therapy, occupational or physical therapy. That's the only difference we found? Okay. With the anti-inflammatory prescriptions or the oral steroids, you know, we talked about the opioid abuse before yesterday. These patients love their opioids because they're in a lot of pain, so they want their narcotics. They're always wanting pain medicines. It's kind of like putting a Band-Aid on it, though. This is an inflammatory problem. So my personal thought, or what I've seen over the years, is these folks do better with anti-inflammatories a lot of times than they do with their pain meds. It's an inflammatory problem. So if they're taking an anti-inflammatory medicine, as we're causing more irritation and swelling with our stretching and our exercises, it tends to limit the kind of reoccurrence or redevelopment. Range of motion exercises, joint mobs, again, according to the process or the time period that they're in, you know, how aggressive those mobs would be. Modalities possibly. You know, one of the things that was mentioned was, like with plantar fascia even, and I know it's been an issue with our clinic, was like the dry needling and the Grassner, or the instrument-assisted stimulation. For things like this, the physicians are fine with it. One thing I would encourage you probably not to do is on a post-surgical for that first 12-week period for sure. And if you have questions with that, before you do that on a post-surgical, I would encourage you to contact the facility. But for your tennis elbows, your frozen shoulders, they're not going to care if you're doing it on that stuff. I mean, if you feel like it's helping, it's an option. All right, so key points to consider. Management of their pain. Again, that's really important. If they're having a lot of pain, they're going to self-limit. They're not going to want to do anything you're showing them. And that's probably the most important thing, is their compliance and their consistency with their home program. You can see these folks every single day, and if they don't do their home program, you're wasting your time and their money. Okay, edema control, it's essential. One of the biggest mistakes I think that we make, and it was a good question that somebody had asked, you know, if you're being really aggressive with therapy and causing irritation, are we making it worse? Probably. So what's really important is that when you do your programs, you should have some kind of an anti-inflammatory type of process that you're having them do. So maybe they'll heat it up, you'll work them really hard, you'll stretch them, but then maybe they finish with ice, or they're taking an oral anti-inflammatory, or something to counteract the inflammation that we're creating. Consistency, I already mentioned that with their home program. Again, as Dr. Norrie mentioned, this goes away on its own if you leave it alone, okay? But it can take forever, and nobody wants to wait 2 to 3 years to get their arm back. So, you know, what I like to tell my patients, again, and this is with that education part, the more consistent they are at home, the faster this is going to go away. Because if I stretch them really hard and they go home and don't do anything, it's just going to scar right back up again. So by us working them hard and breaking these adhesions loose and then using their arm when they get home, they're trying to maintain little bits of improvement every day as they go. Again, the use of modalities is effective. There's not a lot of literature out there, and it's not that I don't think that it actually helps, it's just that there ain't enough good literature out there to support it. You know, with the use of, example, ultrasound. If I have somebody with a lot of posterior capsule tightness, I'll heat up the posterior shoulder and have them work on some internal rotation stretching as I'm doing it. You can see the improvement as you're actually doing it. It's going to tighten up again, but if you can continue that and they can maintain that, they're going to do better with maintaining their motion. And again, pain control with that modalities too. I mean, if we can control their pain, they're going to be more compliant. Strengthening, again, you want to be careful with your strengthening. You don't want to be producing a lot of pain. What I typically tell my patients is when they're stretching, I don't care if they have a little bit of pain. When they're strengthening, I don't want it to hurt. If they're having pain as they're doing it, they're just increasing that inflammatory process. With stretching, as long as it's kind of a low load, long duration stretch, I don't care if they have a little bit of pain. And then again, remember to educate them, because if you educate them on all this stuff, the importance of keeping the inflammation down, the importance of being consistent and compliant, the importance of using the arm as much as they can, it really makes a big difference. And the other thing, again, with the education part that I like to educate my patients on, if it's a diabetic, they need to really control their sugars, otherwise this is a mess, okay? They don't heal fast, they have more adhesion problems. And then another one that I would touch on is smoking, okay? If you've got patients that are seeking narcotics and they're smokers, well, there's good reason. It's been found that nicotine actually stimulates your nerve receptors. So they're having more pain because of the nicotine, so then they're seeking more medicine, which takes, again, on that whole addiction effect, okay? Not to mention, one cigarette restricts blood flow to your arm for an hour. So if you smoke a pack a day, good luck. All right, so phase one, again, is my little fireball here. So this is actually where it's really, really painful, even though it's the freezing phase. They have pain all the time, okay? It aches, it throbs, they don't want to do anything. They think that if they just wait, it'll get better, and then they'll start using it, and it's actually kind of counterproductive. Our goal here is to minimize the adhesions, decrease their pain, and help them to try to maintain strength within their comfort, and encourage functional use. Albina's giving me the red light here, hurry up. Okay, educate patients on expected challenges for the months to come. Okay, that's really important. And our primary goal in this first phase is to typically, again, just decrease their pain, get them out of their self-limiting behavior, and try to keep them consistent with their home program. The frozen phase, again, we're going to work on that range of motion a little more aggressively. Again, we want to continue to manage their pain because they're going to have pain as we're stretching and working them, and then continue with the strengthening. And then we want to encourage the daily functional use. Again, pain is usually a little bit better controlled, so we can start progressing with the stretching, the strengthening, and all those kind of activities. And then the thawing phase. These are the folks that are using their arm a little bit better. They really don't have pain except when they come see you or when they're doing their home program, when they're stretching, trying to get that last little bit of mobility back. So again, we can maybe continue with the mobes here a little bit. One thing I would tell you as far as, do patients have to come to therapy 5 times a week? No. Okay, I really don't think that they do. We see our frozen shoulders typically 2 to 3 times a week, but again, it's because they have to do their home program. I would encourage you to see them once in a while or on a frequent basis, just for the fact that we know where they're still tight. We can hit those areas that are still frozen and work on them a little more aggressively. And then you can change your exercises as they get better and you need to work on new areas. Okay, corticosteroids. It's been found to decrease pain significantly. It's also, there's little evidence that manual therapy are modalities. And again, I think it's just a lack of research more than anything. Okay. I think we've touched on most of those things. Again, it can take up to 2 to 3 years. Pain, again, you can use E-stim, TENS units, anything like that to try to help with their pain. Again, that's one of our primary goals. Motion, if we're, again, out of that first phase and you're trying to get a little more aggressive, you might increase the level of your mobilization techniques. Home program is probably one of the most important parts of their whole process. Again, for edema control, there would be a range of motion. That's your body's natural way of getting rid of swelling and fluid. And then low-grade mobes for helping with that, maybe your thermal modalities. Exercise program, these are just a few of the ones that we typically use, not all of them. Okay, and then just some real general kind of ideas here. I'm going to skip past this stuff because I think we're in a time thing here, but it's in there if you want it. It's just kind of some typical ideas or suggestions for different levels of their treatment. All right, and then our desired outcomes. We want to decrease their pain, reestablish their range of motion, and return them to work activities. All right, adhesive capsulitis is an overactive inflammatory process. Diabetics in females, reoccurrence is fairly low except if they're diabetic. They see that a lot. And then the 3 phases. But most importantly, we want to control their pain and get their motion back. You want to have them be consistent with their home program. And then again, that education and getting them to use their arm for functional motion and strength. All right, and that's it.